Okay.
Mm. Oh, okay.
Am I audible now?
Hmm.
Yes, very clearly. Okay, so I'll start.
Hmm. Start.
Perhaps okay. So my patient, Mrs. ABC, a 40 years old female, resident of Dadar, and housewife by occupation, Hindu by religion,
Hmm.
and right-handed by nature, came to the OPD with chief complaints of bilateral lower limb weakness since 10 days, bilateral loss of lower limb sensation since 10 days, and tingling sensation in the abdomen area since 1 week. Patient was apparently all right 10 days back when she noticed sudden onset weakness in both the lower limbs on climbing downstairs. The weakness progressed and evolved completely over the next week. Patient could not move lower limbs at all when she was admitted 3 days ago. Weakness has improved after hospitalization, but the patient finds her lower limb stiff. Patient also gives a history of loss of all sensations below the level of umbilicus that started 10 days ago and evolved completely in the next 2 to 3 days. Sensations have improved after admission.
Spec, can I just interrupt?
Yeah.
Regarding the weakness of lower limbs, you need to be like more precise regarding that. Like you need to describe where the weakness started. Did it start from proximal or was it distal? Like what did the patient notice? Was she having difficulty in
Okay.
like
Okay.
wearing the slippers, or was she having difficulty waking up from her bed? So like, how did it progress? Was it sudden progression? Was
Hmm.
like
Okay.
there must
Yeah.
be a
So,
progression.
so it started in the ankle region and then it progressed upwards and it reached till the I think she told like I took this case almost 2 3 months back. I don't remember exactly, but she told me okay, like like it evolved as from down to up, like from the ankle till the region of this
Yeah, yeah,
umbilicus.
yeah. But like while describing, no, you need to elicit the history. Like for example, if the weakness is distal, the patient might
Hmm.
have like may tell you an history like yeah, she has difficulty wearing the slippers or kicking.
Hmm.
Like the classical thing, what uh, we had like the patients normally they say like they have difficulty uh, just like they feel like their feet is dragging. So that will tell you like there's something problem with the distal
Hmm.
part of the limb. Then as the
Okay.
weakness progresses, you need to tell the duration of the time, like kitna din se like it like
Hmm.
this day my weakness started where I noticed that she I had difficulty wearing slipper. Gradually it progressed in within a week or 2 weeks. I had difficulty waking standing up from the ground or like standing up from her toilet or something like that, or she needs supports while walking. So that would be the proper history because you need
Hmm.
to like localize the relationship. So is it a proximal weakness or a distal weakness?
This. Okay.
Okay.
Okay. Okay. So
First,
like
because
first aid and okay. Okay. So like
so you
if
just need to
it's
like re-describe the weakness like right now.
hmm.
Uh,
Okay. So okay. So at first the patient like the patient was not able to like the slippers were slipping
hmm.
uh, and then later on after 2 to 3 days the patient also had difficulty from sitting to standing position.
So okay, so the weakness progressed within a week, and was it symmetrical or asymmetrical? Like was it
uh, y-
involving simultaneously two
yes,
limbs?
yes, it was symmetrical, it was involving both the limbs. Mm,
So the weakness progression was symmetrically involved. Okay, like
yes.
asymmetrical. Okay, fine.
Then patient also gave a history of loss of all sensations below the level, and then patient also noticed a tingling sensation in the area of abdomen around umbilicus, completely encircling till the back. Tingling is present intermittently. On inquiry, the patient gives a history of not passing urine for one whole day when she presented to the hospital. Patient gives a history of double vision on seeing on right side 2 years ago that lasted for 1 month and resolved on its own.
Uh, Double vision like diplopia. Okay. That
Uh,
lasted for
1 month, and then it resolved on its own.
so like then you have to describe the diplopia also like
But it
when
was like on the right side 2 years ago.
okay, sorry, I just lost track. The presenting complaint was
Presenting complaint was this lower limb bilateral lower limb weakness since 10 days and bilateral loss of lower limb sensation since 10 days and tingling
okay.
sensation in the abdomen area since 1 week.
Sleek acute onset, and she had an so like this the diplopia is not currently present in the illness, right?
No, it is not present in the chief complaint.
Okay,
Like it
that
does. So I should
okay.
include it in past history. Yeah.
Yeah, yeah, yeah. Do not include it in an HOPI because uh but if you want to include it in HOPI, it should be at the end, I think. Like the first thing is you need to clear you need to like since you're
Okay.
starting with motor weakness, you need to
Hmm.
like say the negative history of all the motor weaknesses, whatever pertinent to that. Then
Okay.
you go with the sensory symptoms. Then you go with large or like small fiber. Then all the negative history you need to tell them. Then you go for cranial nerves. Then for cerebellar. Then autonomic. Then environmental. So
Okay.
you just
Okay.
go by the tracts or start from
Hmm.
the lesion. Like you're starting from corticospinal tract, so go from
Hmm.
there. Like go from spinal cord to upwards.
Okay. So
And the
like
weakness did you like mention the fluctuation? Like was there any diagonal variation?
yeah, like uh, I mentioned as it progress, like the weakness progressed and evolved completely over the next week, and like it was sudden in onset in both the lower limbs on climbing downstairs. So that's what I have mentioned. And it has resolved after hospitalization, but the patient finds her lower limb stiff. Uh,
Okay, right now, what's the degree of weakness like? You need to also tell the degree, like what she's able to do. Like, is she able to lift her limbs? Is she able to walk with the help of support? Is she bedridden?
okay.
Like,
So like I
like,
have included that in examination actually. So
I mean,
uh,
like history, like, you need to give a certain degree of like severity. So helps you in differentials. Like GBS, you
mhm,
have like within a week, the patient will be bedridden, but compressive myelopathy patient can walk for a few days. Stroke, so it differs like tropical spastic paraparesis. Of- You just tell like right now there is a patient bedridden.
hmm,
So
okay.
she
And so she was not bedridden. Like she could stand now, even though she felt like it was very heavy. She could stand. Like not
okay,
able to stand properly. She fell
yeah,
down after standing for 3 or 4 seconds.
okay, she can walk with support, so she can
Huh.
stand. Taken that is enough.
Okay.
Then you go by the negative history of upper limbs, like
Yeah,
then
like I have divided my negative history as anatomical history, then etiological history, and then
okay,
complications history.
okay. Let's hear it. Let's hear it.
Huh. So there is no history of any weakness in the face, upper limbs, and trunk region, or speech difficulties, or decrease in vision, or abnormal movements, or loss of balance. This is for cortex and cerebellar involvement. Then no history of root pain or back pain. This is for any kind of extramedullary compression. No history of sensory dissociation. Then no history of involvement of single muscle group or diurnal variation in weakness.
Diagonal variation, you should mention it with your when you're
HOPI.
describing that weakness. There's no fluctuating weakness. Okay,
Okay.
because that is the thing, na? Like Joby, if you are telling anything pain, you do tell the variation, right? Diagonal variation with time.
Mm, yes.
Right.
Okay.
Yeah, what's the importance of diagonal variation weakness?
Uh, so, like in lower motor neuron lesions like myasthenia gravis and GBS, like basically myasthenia
Yeah,
gravis, what
myasthenia,
happened?
Lambert-Eaton.
So,
Yeah.
and Lambert-Eaton. So, in that, as the day progresses, uh, the patient will start feeling more and more weaker.
Yeah, so that is why like fluctuating weakness is a characteristic of neuromuscular disease. So
Hmm.
you need to mention there on like whenever you mention a type of weakness. So basically, weakness you need to define all these things. Like, is it a first thing you need to define are the regions involved, whether it's the legs, upper limbs, or whatever, trunk
Okay.
or the neck. The next thing you need to clarify is whether the weakness is proximal or distal, and the progression of the weakness, whether the weakness started from distally to proximally or proximally to distal. Then the symmetrical, whether the weakness is symmetrical or asymmetrical. Then the fluctuation. Then you go to the next symptoms.
Okay.
So you need to cover
Okay.
all the aspects of the weaknesses. Only then it's like a complete picture.
Okay.
Then associated symptoms with the weakness, like if she has cramps or fasciculation. That you can say.
Oh. Like, what is the like cramps the issue? Why is that important?
Or nocturnal cramps, like classically you see in LMN diseases and ALS, maybe the ALS, MS. So,
Okay.
and fasciculation, basically ALS.
Hmm. Classic. Okay. Okay.
Now, since you're told the weaknesses just to the lower limbs and upper limbs and all are spared, right? So now you're going to
Yes.
the sensory symptoms. So how will you describe your sensory symptoms?
So, sensory symptoms. Uh, okay. So, like, what I remember is like if we have to describe any symptom
Like,
in
what was the
the
patient's sensory symptoms? What did you describe? Did you
uh,
ask for the like whether the patient can feel things from her foot?
yeah, that's what. So that's what I asked. She could like it felt as if she was walking on rubber.
Uh,
The,
so
and
you need to describe that. Okay, now describe the sensory symptom of that patient.
uh,
HOPI बताओ ना जैसे बता रहे थे.
okay.
You were
So
just telling the मुझे tingling sensation around the umbilicus. Then you went into the
umbilicus,
negative.
yeah. So
I
like
did not
patient all.
describe that sensory symptom of the foot, so that's why.
Hmm. Like in sensory, the like the positive symptom which was present was that there was tingling sensation present around the umbilicus, which was extending till the back region, which signifies that there is a level of demarcation. Like we could localize exactly at what level the lesion is present, and since it is present around the umbilicus, it is basically telling us that T10 is involved and uh, like up till the level of T10, and then um, there was lucky uh, patient also told that there was a history of loss of all sensations below the level of umbilicus that started 10 days ago, and it evolved completely in the next 2 to 3 days, and sensations have improved after admission. So like even the sensory symptoms were present.
Okay,
Like
initially, what kind of sensations like were absent? Could she feel that pain? Could she feel temperature? Could she feel? And you did
so
say there was some paresthesia also, no? Like she feels something walking on a rubber thing.
hmm. So that walking on a rubber thing, that is like one of the characteristic of GBS, and she described that. And
What do you
then
mean by TBS? Like it's a characteristic of large fiber. Just remember that.
okay,
So,
okay,
so the reason why we need to like so sensory also ना उसमें
hmm.
भी आपको बताना होगा proximal से distal
हाँ,
start हो और distal से proximal start हो क्योंकि proximal
okay,
से distal जो start होते हैं वो radiculopathy होता है और distal से proximal जो start होता है वो neuropathy होता है
ये जो होता है, हाँ, yes.
और
So
न्यूरो then again large और small fibers large का symptoms
hmm,
क्या क्या होता है small का क्या होता है वो बताना
हाँ,
होता है
हाँ, okay.
अभी like
So
just अभी एक
yeah,
बार बताना एक what
हाँ,
is the symptom
so इनके केस में लार्ज में तो
what I'm saying is like just describe the HOPI of this patient, the sensory part.
अच्छा, like I haven't written that exactly कि HOPI of sensory part, but like there was no history of sensory dissociation. That is the patient when like she could not feel if the when she went for bathing she could not feel the temperature of the water and stuff, and so if it was hot or cold, and then like when she was wearing her slippers she could not feel those. That's why they were slipping uh, when she was trying to walk. And then other sensory like when she was able to feel the clothes which she was wearing. Like there was no sensory symptom present around the truncal region of the patient. Like when she wore clothes she could feel the clothes. And then these are the sensory symptoms I
That's
remember.
very inner sensations. Also, like, was she able to feel when she able to feel when she defecates, and was she able to feel the water when she washes?
Oh,
That.
okay. Okay, that also I can include, yes.
Another thing you can add is regarding proprioception. So
Hmm.
there's a classic.
Uh-huh. So,
Uh,
so usually in PCT lesions, what happens is when the patient gets up in the morning and they like when they go to the wash basin to apply a face wash or anything, they
uh,
have to close their eyes. So so the balance is lost basically. That is called as wash basin ataxia. It is seen in PCT lesions because proprioception is lost, and when you close the eyes even the visual sensation is lost.
okay,
If
fine.
it was a cerebellar ataxia, then even with the eyes open she would sway. So,
Okay. Now we have finished with this one, right? Weakness and sensory symptoms.
hmm.
Okay.
uh,
Mhm.
then for motor symptoms, so what I remember, like I haven't written it, but then motor symptoms may we have to ask for nutrition history, tone history. For nutrition history, we basically ask if there is any thinning of like if she feels that her hands have gotten thinner, or like the muscles have gotten thinner, which is not seen in acute cases of any LMN lesion. But like ALS in chronic lesions, we can see wasting of muscles. And even in long-standing LMN lesions, we can see wasting of muscles. And if there is there can be pseudo hypertrophy, but it is usually seen in Duchenne muscular dystrophy. And it is not. It is present only in adults. So sorry, in children. So yeah.
ठीक है
And
और ब्लैडर का बता देना ब्लैडर इंपॉर्टेंट है ब्लैडर क्या क्या डिस्क्राइब किया
हाँ, so bladder में uh, um, also in motor baki which is, other history was we have to ask for distal motor and proximal motor. For proximal motor we ask for combing of hair if she is able to comb her hair properly, and for distal motor we ask if she is able to button unbutton her shirt properly.
या वो सब हो गया ना we have
हाँ.
like defined relations now we have defined right now the
Hmm.
weakness is from distal lower limb to extending to the proximal upper sorry to the proximal lower limb and it is just confined to both the lower legs it was symmetrical and
Hmm.
with sensory involvement up to the level of umbilicus and
Hmm.
bladder का आपने कुछ बताया you described
हाँ,
that
bladder का 8 yeah. So on inquiry, the patient gives a history of not passing urine for one whole day when she presented to the hospital.
yeah what you need to ask is whether she could feel the bladder was full so whether she could uh, whether you need to know whether the bladder is an element bladder or a human bladder
Okay.
so so the element the features of element bladder which is overflow incontinence basically the patient it's a sensory bladder so the patient doesn't feel the bladder is full so she'll come when you see the patient will have a full bladder and she doesn't complain any discomfort until it is like it's completely full when it is stretching even the surrounding viscera. So that would be a sensory bladder. Whereas the spastic bladder, which is a human bladder, The
Hmm.
patient presents with a with like will have an increased frequency and will have a
Hmm.
discoordination during urination. The patient has to do certain maneuvers, like he has to sit down to urinate, and basically that would be the symptom of LMN bladder. And
Hmm.
then you have
Uh,
a sphincter.
like atonic bladder also. Hmm.
Then you can have a neuropathic bladder, just like
Hmm.
when you are pudendal neuropathy. So in that patient, the patient can feel the bladder, but he cannot.
Hmm.
Uh,
Why? Yeah,
yeah,
there
he
will
cannot
be
avoid.
overflow incontinence. Hmm.
Yeah, he cannot void the urine because of the sphincter, external urethral sphincters.
Hmm.
So basically, what your patient, you are telling that patient was not able to, like the patient was not passing urine for one whole day, but she was completely, she did not complain of any abdominal discomfort because of that, and she had to be
Yes.
catheterized to pass urine. So that implies the patient has element bladder.
Lemon bladder. Yes.
Okay,
Okay.
and right now, like you have defined the weakness, sensory symptom, and the element bladder. So rest of the symptom,
Hmm.
like rest of the negativity, what and all.
Okay. So for etiological history, I will ask for no history of trauma, injury, or recent exposure to radiation.
Okay, आपने normally like I don't know, but I don't know आपके side में कैसा होता है. But in our side, you have to rule out all the other systems. So I'll assume that all other systems are normal, like
Uh,
cranial nerves,
huh.
autonomic. Autonomic का आपको बताना पड़ेगा, especially when you're dealing with spinal cord. Autonomic का क्या
अच्छा.
क्या पूछते हैं आप लोग?
So autonomic में we ask for any like bowel movements we ask for, and then any history of orthostatic hypotension, like if patient feels giddy after standing up from like
Mhm.
lying down position, and then we ask for if there is impotency, like erectile dysfunction basically.
Yeah, that is quite important that you need to ask with the bladder also.
uh, and then we also ask for what is there, uh, hypotension, impotency, uh,
Like sweating.
sweating, yeah, sweating, and this like lacrimation also, and
Okay,
yeah,
fine. We'll assume that he has
palpitations, palpitations also we can ask for.
okay, he has an autonomic symptom. So okay, fine. So all
Mm,
rest of the negative history is like rest of the neurological negative history is negative. So now
yeah.
etiologically, what and all you'll ask. So
So etiology में like I'll ask for any no history of fever, fatigue, night sweats, anorexia, coughs or cough symptom, which is
started with
ruling out.
backache. Huh? You did tell backache, right?
Yeah, I did say backache.
Okay.
So
Okay.
okay. No, wait. Backache was not. It was like that tingling sensation around the umbilicus was present.
Okay. But she doesn't have vertebral pain. She doesn't
No,
have.
no, she doesn't have vertebral. And
Okay.
also, like I actually wrongly mentioned that the history was like it started from distally to proximal, and it does. The patient gives the history with most of all sensations below that is, she gave the history at the same time. Like the sensations were lost at the same time, pura below the level of umbilicus, and then it progressed over the next 2 to 3 days, and sensations have improved after admission.
Okay. Fine.
Huh. And okay,
No history of
so
trauma.
no history of trauma, injury, or recent exposure to radiation. That will, because since all the there was involvement of like the symptoms were present uh, below the umbilicus, pura ek saath, that's why. And then no history of fever with rash, joint pain, or body ache or diarrhea. It is seen in post-infectious demyelination, like GBS, or yeah, uh, or किसमें yeah, and then no history of recent vaccination, no history of rash, oral ulcers, arthritis, or photosensitivity,
Why that?
To rule out SLE.
Why are you suspecting SLE?
Uh, uh, like,
Like,
mm,
okay, fine, fine. Like, you
it's,
can say anything, you
uh,
can defend anything. In fact, like, but I would want like the more important stuff. Like, if you are like, what is the lesion you are suspecting right now? Is it are you
so,
suspecting a CNS lesion or a spinal cord lesion or a radicular lesion or a nerve lesion?
I'm suspecting spinal cord lesion.
Sorry.
Spinal cord lesion.
Okay, so your history should be relevant to that.
Hmm. So, like
Maybe.
initially, that's why I asked for trauma, then for any port spine, and then any post-infectious demyelination and post-vaccination demyelination. I guess except these four, even yeah, for spinal mets also. So, no history of systemic or blood malignancy, and no history of any surgeries in the past. Any past surgery will indicate if there is thrombosis of pneumonia. That's why I asked.
Okay, fine.
And there is no similar history in the past or in the other family members. So if it is present in other family members, then it could indicate toward hereditary spastic paralysis.
Okay. The past history, what you had mentioned, she had a diplopia 1 year ago
Two, like 2 years ago, that lasted for 1 month.
that lasted for 1 month and it disappeared on its own.
Yeah.
Okay, fine.
Hmm.
And other systemic negative states, there's no other systems involvement,
Hmm.
CVS, RS, and Paraplegia.
I think the significance of past history of double vision could be an attack of multiple sclerosis, which resolved in 1 month on its own, and which was present on the right side 2 years ago. That was an attack of multiple sclerosis.
Why do you say it's multiple sclerosis when we never see diplopia in multiple sclerosis?
Okay. अच्छा,
Mm.
okay.
Multiple sclerosis is a lesion of CNS. So diplopia हुआ तो न्यूरोपैथी होता है ना? Like it should be an involvement of brain stem or वैसा the
Huh.
no
So like,
abduction of that.
so till now, basically, what my suspicion, which was there was that, like there was a past history of attack of diplopia, and now it is a picture of a transverse myelitis kind of picture now, because there was like loss of sensation suddenly
So
of all the parts, and
that
that's
will
why I
be
was
discussed after the diagnosis, not like
okay. So okay, okay.
right now you are localized your lesion to the spinal cord and you're thinking
Hmm.
it's an intermedullary type
Uh,
like,
yeah, intramedullary type, yes.
because because
Uh, 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 like there is no radicular pain, or if like radicular pain could be present in this any prolapse intervertebral disc, so that is an extra medullary
yeah the most important thing is
compression.
the symmetrical involvement
Yeah, symmetrical involvement,
and
yes.
early bowel bladder involvement
Hmm.
and take it. So no
The,
you then whatever next is general
so
physical.
like complication history में no history of burning aspiration and no history of blood flow.
Okay, fine. Blood source and blah blah blah.
Hmm. The consistent history of diabetes, hypertension, or past history of hospitalization. The personal history, patient consumes a mixed diet, appetite, sleep, and bowel movements are unaltered. No history of any lifestyle of smoking, alcoholism, or diabetes.
तुम्हारी वॉइस मफल हो रही है स्क्वायर बीच बीच में.
Okay, एक second.
Okay. Nutrition is quite important, no? Yes, no?
Hmm. Yeah. Okay.
What's the differentials for spinal cord with nutrition?
Um, okay. Spinal cord with nutrition. Okay. Uh, mm,
Oh, B12 deficiency, selective.
oh shit. Okay. Yeah. Okay. Sorry. ये तो पता, ठीक है.
That and
Uh,
another one is hypocypremia, like copper deficiency,
hmm. Hmm.
and pyridoxine toxicity.
Okay. Yes.
So these three you can remember. Nutrition.
Hmm. Hypocupric is a close differential for STDC.
Yeah, yeah.
Yeah. Okay. Uh, कहाँ गया? Yeah. So, personal history में no history of any addiction to smoking or alcoholism or IV drug abuse. Appetite, sleep, and bowel movements are unaltered.
Okay.
Then, family history, no similar history in family members. No history of TB in family members. Uh, Drug history, patient was not on any medications previously. Example OCPs. Then vaccination history, patient
Why specifically OCP?
because OCPs can cause this yeah hypercoagulable state. So there can
Cortical.
be so
They are not suspecting cortical vein thrombosis. They'll have
uh,
fever, seizures.
yeah.
Uh, yeah, it's just you don't have those extra things.
Okay. Then vaccination history, patient reports to have been vaccinated against poliomyelitis. And then menstrual history, last menstrual period was on 1st October 2020, and menstruation is regular without excessive blood loss. Uh, okay. So, do I give my provisional diagnosis or start with general examination?
Yeah, you can actually like tell your professional what do you feel the lesion is.
Okay, so I feel that it could be a case of transverse myelitis, which could most likely be due to multiple sclerosis or NMO or any mixed infection.
Transverse myelitis is enough, like MS,
I
NMO.
was suspecting MS because there was a attack of diplopia 2 years back.
Yeah, but it's not an hardcore thing because we have a cyanocones of MS. So diplopia doesn't actually come with their MS.
But
Uh,
that internuclear ophthalmoplegia is not diplopia only, ka?
Bilateral INO, it is MS. Uh, like tic Dorolax, bilateral trigeminal neuralgia, cerebellar involvement, and there are three more cyanocones I forgot. But if take a fine, you can consider it MS. You can even consider limes also. So there are a lot of differentials. So you just name the lesion. Etiology will like speculate later. Transverse myelitis is more than enough.
Okay. Then general examination, patient is conscious, cooperative and well oriented to time patient person. Patient is averagely built and nourished. Attitude
The
patient.
only thing they might ask is why is it not a radical? Or like why is it not CIDP? So
Okay, so CIDP, since the symptoms were they extend beyond the period of 1 month usually in CIDP,
uh,
and acute is within 1 month. That's and the
um,
patient only had like a 10 days history. That's why CIDP is
uh, yeah, why is it not AIDP?
It is not AIDP because in AIDP what happens is there is progression from distal to proximal, and in this case there is involvement of all of the
Distal to proximal.
in AIDP.
Such a proximal case.
AIDP is this okay. AIDP is GVS only, no?
GPS something.
So GVS is distal to proximal, no?
Okay, okay. Yeah. I mean, like the weakness is ascending, but the lesions, like it will be because it's a large fiber involvement. Uh, so,
Acha.
so theoretically, the when you have a large fiber involvement, it's always proximal followed by distal. So when it's a
Okay.
small fiber involvement, like in diabetic neuropathy, it starts distally to proximal. But actually like they call it an ascending paralysis because it starts in lower limb, then it involves upper limb, then it involves your autonomic things.
Acha.
So it's fine. Uh, so yeah, it's not AIDP because you have a clear cut bladder involvement. So it's not.
Hmm. Okay, that is also interesting.
And the weakness is not
In
progressive.
G like can't GBS involve bowel and bladder? Like I saw one patient who had bowel bladder disturbances even though he was a suffered case of GBS.
I can like अभी तक तो मैंने देखा नहीं but uh, but if you have a like clear cut uh, if it's quite aggressive, quite diffuse, then they might have like asthma and they when they have sensory motor axonal neuropathy, then they can have bladder involvement. But most of the time they don't actually.
Okay.
So
Okay.
why did they diagnose him as GBS? Like
Yeah, so there was involvement of even the third nerve was involved उनके case में, and there was a history of diarrhea present 2 weeks back, and it was ascending paralysis only, and the single breath count test was also positive. Patient was like I think we counted 20 now normally. So उनके case में it was very less. The single breath count was less than 10 something, and that's why they suspected him to have GBS. And
uh,
he was on medications also.
on medication for GBS.
Yeah, IVIG was being given to him.
Okay. Yeah, that is like normally whenever we have a rapidly progressing paralysis with uh, respiratory involvement, GBS, and second differential
Mm.
is myasthenia crisis. So we do start IVIG before investigations. So
Oh,
दोनों में भी
okay.
IVIG काम करता है, then we look at investigations and this differential.
Mm.
Okay,
Okay.
now go for exam.
Huh. So, examination. Attitude. Patient is lying supine with arms by the side of the body and both the lower limbs adducted and extended at hip and knee joints and plantar flexed. Vitals. Temperature is afebrile. Pressure is 130 by 80 mmHg in right upper limb taken in supine position. Respiratory rate is 20 per minute regular. Pulse is 76 per minute regular and good volume normal character equal on both sides. In radial artery, peripheral pulses are felt regular. No evidence of atherosclerosis in peripheral arteries. No apex pulse deficit found and no carotid bruit present. No pallor, icterus, cyanosis, clubbing, lymphadenopathy and edema was seen. Well, skin spine is normal. Was normal. Then no stigmata of TB or syphilis present. No signs of atherosclerosis. Patient has IV line secured on left arm and Foley's catheter in situ. Uh, Hello.
Yeah, you just look for nutritional deficiencies and stuff, and mm, like
Okay.
neurocutaneous markers, 8 to 2 examination. I don't think there's anything specific in general. There's just one
Bishop,
uh,
there's a car coming.
Viva question, what is Gutman sign? You can just look it up.
कौन सा साइन?
Gutman sign.
गट में?
I think वो hemiparesis में होगा, I think. It's basically flushing near your nose because of autonomic involvement. I don't think anyone would ask that. Just for knowledge sake.
Okay. Okay.
So you measured BP, na? BP you have to measure both on supine and standing position.
Okay. Okay. To rule out orthostatic hypotension.
Yeah, you need to like rule out autonomic involvement. So when do you call orthostatic hypotension?
When there is drop of more than 20 mmHg, when the patient stands from supine position.
Till what, like kitna minutes? 3 minutes.
3 minutes. Okay.
So you need to measure after 3 minutes. So if the drop is persistent after 3 minutes, then it's orthostatic.
Okay. Okay.
And 2010 is the probable actually. I think Harrison is 2010, right?
Yes, like 20 for
Um,
systolic and 10 for diastolic.
yeah, but like 30 is like confirmatory. That's what like Bradley says. I think 2010 is fine.
Okay. So, hmm. Then, uh, shall I start CNS examination?
Yeah, sure.
So, higher mental functions, behavior is normal and follows simple commands. Speech and language are normal. Immediate, long-term, short-term memory is intact. And yes, then neg rigidity is absent. Kernick sign is absent, and
That will
Reitzert.
be, no, mental science you shouldn't involve in mental functions. So to बाद में डाल last में. So
Okay.
higher mental functions, memory you told like immediate. How actually you need to tell how did you test, but that you read up. Okay, कैसे test करते हैं
Like,
immediate
हाँ,
long.
short term
Yeah,
में we ask what did they eat the previous day. Immediate में we like ask them to recall, like repeat what you have just like give them a number or OTP kind of stuff.
yeah,
And
see,
in
yeah, CS
and
subtraction you do for immediate or
for long term we ask them like their anniversary का date and birthdays, like
yeah, ठीक है उसमें भी दो तरीका होता है एक सिमेंटिक होगा और एक ठीक है फाइन नॉमिनल और फिर मेमोरी हो गया then you speech you include articulation and language.
हाँ speech में yes. So like uh, uh, so like if there is sensory, so like are you asking about sensory aphasia and motor aphasia?
Yeah, I don't think it's required for your case because you can actually skip it. You can
हाँ
miss it because you're not even suspecting a cortical
it,
lesion. So you can
that
skip the aphasia and dysarticulation, but you can just say like speech is normal. So you test for
so
memory, cognition, speech, and
so higher mental status was normal, like and then cranial nerve examinations may be all cranial nerves function normally, and motor functions may no nutrition, no wasting of muscles. Tone may upper limb normal tone in both upper limbs, lower limb tone is increased in both the lower limbs, and clasp knife spasticity in extensor muscles present. And power in the upper limb is 5 by 5 on the right side, and left side may be 5 by 5. In the lower limb, it is at the ankle, knee, and hip. It is 3 by 5 on right and left both sides. And coordination is normal in the upper limbs, could not be assessed in lower limbs. No involuntary movement seen.
why couldn't you assess proprioception in Berlin? You can assess. Uh, yeah, but obviously without beds patients के बिना कैसे? You can actually
Uh,
do it. You just need to hold a big toe. Okay.
हाँ
So
no,
they,
I was coordination and proprioception same है क्या?
no, no, you are
हाँ,
telling coordination.
yeah, I'm telling coordination.
Okay, okay.
Uh, then sensory examination. Superficial touch, pain, temperature is lost symmetrically below the level of umbilicus, and deep sensation, position, vibration, joint sensations is lost in both the lower levels. And cortical sensation में tactile localization,
Right.
2 point discrete.
No,
हाँ.
no, actually, you should like tell me the level. Like vibration was lost till which level? The touch was lost till which level? Pain was lost at which level? Temperature is lost at which level? It's quite important.
Oh, okay. So, like vibration and like complete lower limbs, vibration, position, and joint sensations were not felt. And
Where and all did you test for vibration in your lower limbs?
so on the malleolus, then patella, ASIS, and like that is a part of pelvis though. And
Okay.
yeah, like malleolus, patella are the main areas where we check in
Okay,
the
fine.
lower limb and the lower limb.
Before I process ribs. Okay.
And
So there
okay.
was a pan-sensory loss from the level of umbilicus.
And like till the umbilicus level, uh, this all these position and uh, like touch sensation was also lost. Touch pain pressure, touch pain temperature lost symmetrically below the level of umbilicus.
Okay, fine. Then rhomboid.
Reflexes, हाँ, okay, Romberg sign, क्या? Romberg sign, I did not check for Romberg sign in this patient because the patient was not able to stand properly.
Okay, fine. Then
Then,
reflexes.
reflexes, superficial reflexes, plantar reflex, extensors on both the sides, and Babinski sign is present. And abdominal reflex, Beaver sign was present.
No, no, abdominal reflex is not beaver sign. Beaver sign is basically you ask the patient to lift. उठने के लिए
Uh,
बोलते हो जब
uh,
then umbilicus moves.
then
That's not
umbilicus
that's
moves.
not abdominal reflex. That is different.
Okay.
Abdominal reflex you test by stroking the quadrants of the abdomen. So what would you
Hmm.
expect in this? What do you expect in a UMN lesion? What would you expect in an LMN lesion for abdominal reflex?
So, like in if there is a lesion above the level of T10,
Hmm.
and when we stroke, then like the umbilicus will not move upwards. Like if you stroke, like we have to stroke from periphery to the center. So, if there is a lesion and if you are stroking it above the umbilicus from periphery to the center, then like usually the umbilicus moves toward moves upwards, and when we stroke from periphery to the center down below the umbilicus, then it moves downwards. So, in case of lesion, LMN lesion above the level of T10, there the umbilicus won't move, and below the lesion also umbilicus won't move if the lesion is present below. But above, if we try to do it above, then it will move upwards.
Okay, fine.
Then superficial reflex. Okay, these are done. Then deep tendon reflexes.
Broadly, we have bulbar cavernous and both are both important.
अच्छा, okay. Bulbo cavernous reflex नहीं
Okay.
किया, but I didn't do that.
Yeah, करना है because it is not
Okay.
only important for uh, localization, it's also important for prognostication. So,
Like spinal shock.
yeah,
Yes.
if
Okay.
the patient has bulbocavernar reflex on this weakness is still 1 by 5, then
Hmm.
the prognosis is bad. If the bulbocavernar has not yet recovered
Hmm.
and its weakness is 1 by 5, there's a chance of recovery. the patient is still in spinal shock. So that's the importance of the.
Okay.
Okay,
Yes.
fine.
Mm.
So uh, I'm assuming it is normal.
Then knee jerk and ankle jerk were 3 plus. All other upper limb reflexes were 2 plus. Clonus is absent.
You
Uh,
know what is inverse reflex, no?
in inverse.
Yeah.
I don't.
Uh, for example, if you have an inverse reflex at if you have an inverse triceps reflex, inverse biceps reflex, what does it imply? Basically, क्या होता है, when you tap bicipital tendon,
Mm.
it flexes your elbow joint, right?
Yes.
The flexion, if the response is an extension, like then it's called an inverted biceps reflex.
Oh,
So that means like the lesion, it's a localizing lesion. So if you have an inverted reflex at any point, it implies that lesion is at that level. So inverted reflex, inverted biceps, the lesion would be C5, C6. Inverted triceps, the lesion would be C7, C8.
oh, okay.
Sorry, C7.
Okay. So, CNS examination is done. Gait and stance could not be assessed.
Gait couldn't be assessed, no?
Hmm.
Gait में you what and all you assess?
Okay. So, gait में like okay. So like gait में क्या बोलते हैं like uh,
First you see the
uh,
base of its feet,
okay.
base
Okay.
cadence, like how fast he walks, the posture, the way
Okay.
whether it's stooping or straight, and the arm swing. So
Okay.
those are the four components of gait you need to assess.
Okay. Gait I haven't read actually. I'll read it.
Yeah, like when you're writing examination, you just focus on it. For
Hmm.
example, a cerebellar gait, you describe it as a wide base with a
Hmm.
normal posture with a wide arm swing.
Okay.
Festinant gait, a narrow base with a stooped posture with a small, with the narrow arm swing, high, high cadence. So that's how we describe gait. And then you do a back examination, then you do a meningeal science examination, meningeal science.
Okay.
So, and in this case, you do a additional tests like क्या करते हैं?
Uh, इसमें additional. I guess we can do those Oppenheim, Schauffer's, and
Those are
this.
variants of Babinski.
Uh, yes,
Uh,
variant.
what what I mean, like you need to do SLR tests and stuff, like basically to
Okay,
test.
okay. For PIVD, as a straight leg reason.
Yeah,
So,
quadratic thing.
okay,
Okay, so
okay.
then now
Then
you
systemic examination. On CVS examination, no murmurs were heard. Carotid pulsation bilaterally equal and adequate. All other peripheral pulses normal. Abdomen examination, no liver or spleen enlargement, no fluid collection in the abdomen. Respiratory examination, air entry bilaterally equal.
uh,
Can I give my
RS
diagnosis? Uh-huh.
RS में एक चीज कर सकते हो. Since your lesion is at lower level, like for example, if your lesion is somewhere near C2, C3, something higher level, तो फिर तुम्हें diaphragmatic function test करना पड़ेगा. So
Okay.
that you can do through two mechanisms. एक, you know tidal percussion, right?
Yes.
So you need to do a tidal percussion and need to check like what's the
Okay.
span of the like how much how like tidal percussion basically tells you that the diaphragm is moving up and down, right? So you need
Hmm.
to measure the distance, and there are couple of signs like Hoover sign and those stuff like. You just see the diaphragm is working or not. So that you can like I don't think any consultants like कोई भी नहीं पूछेंगे, but I feel it is important.
Yeah.
It
Okay.
it tells you that diaphragm is involved. Obviously, if the diaphragm is involved, patient so will be on ventilation. But
Hmm. Yes. एक second. Charles. Then,
but
okay.
that
So should
like
I give my diagnosis?
yeah,
So Mrs. ABC, 40-year-old female, presented with weakness and loss of sensations in both lower limbs with segmental paresthesia, is a case of UMN paraparesis in extension, most likely due to non-compressive myelopathy at T10 level, due to transverse myelitis and a suspected case of multiple sclerosis without any complications.
multiple sclerosis. Okay, fine. Yeah, anyway, UMN तो पता है. But you do not have any this one right cranial nerves upper.
Cranial nerves में नहीं, no
And let's say
involvement.
post-infectious. I would go with post-infectious transverse myelitis.
But
MS.
history of fever भी तो नहीं था ना?
But it doesn't matter. Like fever is not necessary. इसका फिर ठीक है fine. Probable MS.
So we'll do MRI of brain to look for gliosis. आणि like बाकी investigations अच्छे से नहीं आ रहा है.
How often do you see transverse myelitis in MS? Next, typically.
Like उस टाइम पे the time we took it उस टाइम पे like एक केस था, so हम लोग ने जाके ले लिया.
Okay.
फिर
उसके MRI में क्या आया?
we didn't follow up. हम लोगों ने लिया and then we presented.
Okay.
बाकी yeah. It was like I took this case uh, during like in my third year only.
So what are the like stereotypical areas of involvement in MS? What's the thing? It's an MS.
Okay. Uh,
Report. And what are the stereotypical areas involved in neuromyelitis?
Neuromyelitis optica, it is that I know it has optic neuritis and transverse myelitis basically. And antibodies against aquaporin 4 is formed in those
What's the
patients.
difference between optic neuritis of an MS and the neuromyelitis? What's the difference between a transverse myelitis and a MS versus neuromyelitis?
Uh, I don't think I know.
Okay, it's fine. For your level, this is fine, dude. It's better, but I think you need to fine tune the basically the
Yeah,
HOPI.
HOPI, yeah. And even the negative history में motor, sensory and autonomic वाला.
Yeah. So basically, you just need to keep a format of that CNS system. So,
Hmm.
and for
Like,
everything, basically, you need to like tell like your history should tell the lesion. Like you, when you're describing weakness, you need to tell like what type of weakness is it, a proximal or is it a distal. So you need to like keep a diagnosis in mind. जब proximal बोलोगे तो you'll be thinking of muscle related diseases. When you tell about distal, you'll be thinking of a nerve related disease. So if it's asymmetrical, symmetrical, also be important. Sensory में then sensory में you need to like sensory. There are like many methods people take. Like our professors teach us like this method, like go with posterior column, then with lateral spinothalamic tract and that. But I prefer the large fiber versus small fiber symptoms. So you just need to know what are the symptoms in large fibers, what are the symptoms in small fibers. So
usually, like negative symptoms are present in large fiber and positive in small fiber. Na?
Yeah, numbness, tingling, not necessarily. Tingling sensation is a part of large fiber actually, whereas
Okay.
pricking sensation is a part of small fiber.
Okay. Okay.
Then foot drops. So, okay. Like when you are describing a distal lesion of the foot, mm, that you need to describe like how is it a foot drop? Like is it a nice stepping gait? Is it like whether he जब तुम चलाते हो ना पेशेंट को चलाते हो ना वो भी इम्पोर्टेंट होता है like whether the patient puts his foot on the heel or does it uses the balls of the toes to support his stance. Maybe
Oh,
yeah, one tells a different region than another one tells a different region.
like what is the food?
Like foot drop, the patient starts with this. He places the ball of the foot, whereas in
Okay.
the eye stepping gait, which you see in posterior column thing, so they start
Hmm.
with the heels.
Oh, okay. Okay. Nice. Um,
ठीक है, आपने डायग्नोसिस क्या बताया? और
like multiple sclerosis
मैंने दैट्स इट
and like transverse myelitis basically.
पैरापेरासिस with sensory
UMN
motor,
paraparesis in extension.
with sensory motor and bladder involvement with element bladder
With
with element bladder with element bladder possibly intramedullary myelopathy, possibly transverse myelitis. Etiology could be post infection versus MS or whatever.
hmm,
Like
yes, yeah,
follow up कर लेना केस को देखना क्या क्या. Is it in KM?
yeah.
Where's the
Like
patient?
अभी तो नहीं है, एक साल पहले का केसेस है, like last year she was there in our ward.
Okay, पुराना केस है.
हाँ,
Okay.
अभी like today I took a case of ये like हम लोगों को वैसे आज सच एग्जाम केस मिला नहीं, so the patient को AML था and she had MR, severe MR also. तो फिर जाके MR का symptomology पूछ लिया, but she had pneumonia also because pancytopenia था ना, and like her counts were like only 7 to 8% neutrophils were there when I saw the blood report, and KM